Thank you. I will just share my slides. Hopefully people can see those. Are they coming up?
Yeah, they're coming up.
Excellent, thank you. So thank you for that introduction. I'm just looking at some of the names that have come through. I can see quite a few people that I know, which is great. For anyone that doesn't know me, my name's Emma Coleman. I'm the Safeguarding Adult Board Manager for Nottingham City. Been in post for about 2.5 years. Before that, I was with the Isle of Wight Safeguarding Adult Board for about 8 years. And I'm going to be talking to you today about learning from safeguarding adult reviews in relation specifically to institutional discharge. And this is around discharge from secure mental health settings and prisons as well. So in case you don't know what a safeguarding adult board is and how my role fits into this, I'll give a very quick introduction. So under the Section 43 of the Care Act, every local authority must set up a safeguarding adult board. Now, the remit of the board is to assure itself that local safeguarding arrangements and partners act to help and protect adults in its area who meet the criteria set out in paragraph 42. And this is adults with care and support needs that are at risk of or experiencing abuse or neglect, and because of those care and support needs are unable to protect themselves. So it's quite a specific focus of the board. It doesn't cover everybody. And what the board must do, we've got 3 things that have been set out in legislation that we have to do. We have to publish a strategic plan, and this is reviewed every year. We have to publish an annual report. And this 3rd one, which is the most relevant for today, is we have to conduct safeguarding adult reviews in accordance with Section 44 of the Care Act. Now, what we don't do, receive or process safeguarding referrals. This would go through the safeguarding team that sits within the local authority in adult social care. We wouldn't have any involvement in those safeguarding cases. The board itself is strategic. So we don't have involvement in operational cases. We can have cases referred to us for a safeguarding adult review, but in the day-to-day operational work, we don't have any involvement in that. Acting as an industry regulator for agencies involved in safeguarding, that would be people like CQC, for example. The board is not an industry regulator, so we don't have oversight of the services. We can make recommendations on how they can do things differently. Handle complaints about agencies or staff members. I know most agencies will have their own internal complaints procedures and escalation policies. The board wouldn't necessarily be the place for those complaints to come to. And we don't look at wider system issues outside statutory safeguarding for individuals who meet criteria set out in the Care Act. We sometimes can, with a focus on prevention, but the main focus of the board is for those that would meet the Section 42 criteria. So that's just a little bit about the board in case you're not familiar with what the board are and what they do. So the bit that we're going to focus on today is around safeguarding adult reviews, which, as I've said, is something that every single safeguarding adult board across the country has to do. We do have some set criteria and legislation that we have to stick to. So we have to arrange a safeguarding adult review when it's an adult with care and support needs in our local area, has died or experienced significant harm, and this has been as a result of abuse and neglect. And there is concern that partner agencies could have worked more effectively to protect the person at risk. And we have to look at all those criteria. So the purpose of a SAR is not to hold any individual or organisation to account. There are a whole range of other processes in place for that. What we're looking for is really about learning lessons for the future so that all organisations involved can improve as a result. And sometimes it's not just about saying, did an agency meet its statutory duty? Because sometimes all agencies have met their statutory duty. It's about saying, well, let's think outside the box here. What other processes could be introduced that could have made a difference? How can things be done in a different way? And that's really the purpose and the focus of a safeguarding adult review. They are separate from other investigations. So when there is a death, you can have CQC involved, you can have the coroner involved, there can be criminal and civil courts. We're separate from those, although we do sometimes liaise with those when they're going on, and the SAR can inform some of those processes as well. So when we think about what we're going to look at today in terms of SMD and institutional discharge, how this came about is there was an institutional discharge working group as part of the SMD work stream. And from that, we sent a request out to all safeguarding adult boards in the country, that's 128 of them, saying, you know, we're trying to do some work locally on institutional discharge, what works well, what doesn't. And this is a really good resource of information with the SARs to learn how things have been done in other areas and maybe highlight some of the things that have gone wrong and some of the things that were done well. So from that request, we got 18 back. The ones that we got back covered 21 individuals, some of them with thematic reviews, and they covered more than one person. They came from a total of 12 local authority areas all across the country. And we had 5 volunteers from the group to go through some of these SARs and pick out some of the learning. Now, when we look at a SAR, they usually have a series of recommendations at the end, between sort of 5 and 10. The purpose of reviewing these was not to look at those recommendations necessarily, but to try and read between the lines and pull out some of the themes that weren't necessarily in the recommendations, but they were coming through quite strongly as areas for improvement or areas of good practice. The learning then went back to the institutional discharge working group. There were 3 bits that we were looking for when we were looking through these. So potential leads for support and resources. For example, if another area had a post in place, one example is one area in their local hospital, they had a homelessness liaison support worker. It would be about contacting that area and saying, could we possibly have a look at the job description? Can you tell us a little bit more about how this works? And seeing if we can replicate that locally. We also looked at potential policy process changes and additions. That list is still being compiled, and that is going to go to the Safeguarding Adult Board to be shared more widely. And this one here, this is the one we're doing today, and it's learning to be added into training, examples of good practice and tips for frontline practitioners. The approach for today, we've picked out 3 cases that we're going to look at. So we're going to look at the key learning from them. We're going to look at the crossover with the national second SAR analysis. And then we're going to go through some tools that can help you in your practice. So we are going to make a start with the first case. This was Thomas. So Thomas was only 27 years old when he died. He was found dead by police in a flat that he'd very recently moved to. When we think about some of his history, he had a diagnosis of mental and behavioural disorder and unstable personality disorder. He did use drugs and other psychoactive substances, and it was believed that these exacerbated those disorders. He'd been open to mental health services since 2012, so quite a long time and quite a long history of being open to mental health services. When looking through some of his documentation and his medical history, there were numerous challenges, including drug and alcohol misuse, suicidal ideation, periods of mental health hospitalisation in secure units, also some self-discharge from hospital, self-neglect featured quite heavily. He had periods of housing crises and periods of non-engagement with services. He also had features of PTSD. Now, when I say non-engagement with services, I will come on a little bit later about some of the language that we use about when people don't engage. But for these cases, I am using the language that was actually in the Safeguarding Adult Review and have just copied it from there. So we will be looking at that a little bit later. So Thomas had been a victim of violence as well, but he also had offences for assault, burglary, public order offences, shoplifting, vehicle crime, and these were all dating back to 2011. And when he was 19, he had actually been in prison for 2 years as well. Thinking about his earlier life as well, what came through in the SAR was that he had experienced quite a difficult early life. He was taken into care when he was 5. His biological father had been imprisoned for murder, and from the age of 7, he had been physically abused at home. And when he died, the inquest had recorded his cause of death to be multiple drug toxicity. That's a little bit of a background about who Thomas was and some of the information that was shared in the SAR. We're going to move on to some key areas of learning from that SAR, and these are the things that came through. There's some general ones and there's some quite specific ones as well. One of the key ones that came through was he was not assessed as priority need when he was attempting to arrange accommodation for his discharge from psychiatric hospital. However, The application made didn't have key information, and this because adult social care had not been involved in the discharge planning. Not only had there been not all the agencies involved that should have been, which resulted in him not being priority need when he should have been, there was no evidence of this being challenged by anyone in any of the agencies and saying, I think this needs to be relooked at. I think some information is missing. So that came through as a real missed opportunity in that SAR. At several points throughout his history, his mental capacity was assessed. Practitioners had exhibited difficulty in considering executive and decisional capacity, and this is where somebody appears to be able to have mental capacity, but they can't put those things into practice. I'm not a Mental Capacity Act expert. It is a difficult area to look at, so there are some resources in some of the slides further on. So practitioners also didn't make safeguarding referrals as Thomas didn't consent to them, and there seemed to be a little bit of a misunderstanding about when consent can and should be overridden. Some of the other main features that came through were professional curiosity, and really, I guess, a lack of professional curiosity in that case. Multi-agency working came through as well. Mental capacity, understanding and assessing mental capacity, and also that information sharing and consent as well. I'm just going to pause for a minute and see if from that information, are there any other key themes that anybody pulled out? I'm not sure if I can see the chat, but I will have a little look and see if there's anything that people had put. In terms of when we were working with him, what other things came through as a theme that could have been considered? And this might be the moment where everybody goes a little bit shy and doesn't want to join in, and that's fine. I will just give it a minute. So we've got the main ones of professional curiosity, mental capacity, agencies working together. Anything else that maybe struck you from Thomas's history, things that people maybe should have considered when they were working with him? Trauma-informed approach, excellent. That's exactly what I was looking for. So yes, that's one of the main ones. He did have quite a traumatic history. He was also showing signs of PTSD. And it didn't come through that was considered in any of his assessments or any of the work that people were doing with him. Anything else that people have picked out? There was really sort of two main ones on top of those that I'd picked out. Trauma-informed practice was the first. No, that's fine. The second one was escalation and challenge. That there may have been other diagnoses that had not been considered exactly. Neurodivergence, exactly. Yeah, one of those key themes as well. And it's about understanding the person that you're working with and allowing them to get the right support that they need in terms of diagnosis and signposting if you think they may need it. So escalation and challenge was another one that came through. And I know this is an area that people find difficult, especially when people from maybe the third sector may be working with statutory organisations. It can be quite difficult to say, I'm not sure I agree with that decision. I think this should be done again. I'm going to question that. It can be quite hard to do, but it is quite an important thing. It could have made potentially quite a big difference in this case if agencies and people working with Thomas had said, I don't feel comfortable with that decision. I think it hasn't been made on the correct basis. So escalation and challenge was something that came through from that one as well. So just a couple of questions, really. I guess the first one is a show of hands. Are these themes what you expected? When you think about the themes from institutional discharge, I guess thumbs up if these are things that you expected to see. So we have quite a few thumbs up. None of the themes here are particularly new themes or anything unexpected. Are they new to you, or do they kind of reinforce what you already knew? Feel free to put your answer in the chat. They're not particularly new to me, but that's because I've been working with SARs for around 10 years now, and we do see the same things coming up time and time again. there is a third question there. Why are they so difficult to overcome? And this will be, unfortunately, reinforce what you already knew, which was what I was expecting people to say as well. We do have a third question about why these things are so difficult to overcome. If the same things keep coming up time and time again in these reviews and in practice, why are they so difficult to change? What are the barriers? Feel free to put these in the chat. The chat is open for the whole time. You don't have to answer this now. What we've also got is, I understand that you may have barriers that you don't want to raise in this forum. They may be because they are something in your own agency or people you work with. That's fine. I understand that. What we've set up is we have set up a Microsoft Forms, which is anonymous. And I believe the link to that is in the chat, or is about to be put in the chat. And we'll leave that open for a couple of weeks. And this is really an opportunity for you to say, I see these things in practice, but this is what's stopping me make a change. And this will be fed back to the Safeguarding Adult Board, and it is an opportunity to potentially make a change in this area. Fixed service threshold, absolutely, yes. Hierarchy of professionals, skill of workers, skill of workers, having confidence in these things and having the support, I think, from managers and from leadership as well to be able to put learning into practice. So we'll keep these questions going through each of the 3 cases, and feel free to put them through the chat even if we've moved on, because they will all be looked at afterwards, and I will be compiling a lot of these and taking them back to the board so that we're not just sharing information with you today, we are actually going to be able to do something about it, hopefully too. So a couple of resources to help with these. Now, professional curiosity and trauma-informed practice came up as 2 of the main themes there. But there are some tools that can potentially help in this practice as well. And I'm going to see if I can go through some of these. So the first one is about professional curiosity. Now, we have a national SAB managers network, and we try and work together on looking at some resources and tools for professionals. And this one was around professional curiosity, and the link is on the slides, and the link is also on our website, and I'll give you the link to our website at the end. And this resource on professional curiosity is split into different parts. So it's really for everyone to be able to access. So there are some organisational ones, and this is for really people in leadership roles and director roles to be looking at and saying, does my agency or does my organisation have a culture of openness? Do we encourage that in staff? Do we have the right policies and procedures in place? When we looked at missed appointments, is it 3 strikes and you're out? Or are we looking at the questions about why they're not coming to those appointments, why they're cancelling? Do we have the right learning and development in our agency? Do we have the right supervision and support structure as well? There are ones for managers, and it's the same 4 themes coming through. How can I proactively as a manager promote a positive culture and talk about learning and let my team know that they can share issues and concerns, and we get to support each other as well? And there are also ones for practitioners as well. How can I contribute to the culture of organisation by being open and transparent with everybody? It's my responsibility to read and keep updated on policies and procedures. Do I have the right reflective supervision, or do I have an opportunity to discuss things that don't sit right with me? And have I got the time and connections to actually be professionally curious? It moves on to effective engagement, and non-engagement comes up later on as well, but there's some really good bits I want to go through with you here as well. And these are just really some top tips that can help you in those really difficult conversations with people. Asking a person to tell you a story about themselves or their past. What are they proud of? Is there anything that still worries them? It's about getting to know the person wider than that presenting issue that they're seeing you for. Ask them what helps them when things get difficult. What support network do they have? What tools do they have when it comes to their resilience? And then things like body language. Don't look shocked or uncomfortable if you hear something that you weren't expecting. Try and be open and positive, and be mindful of your facial expression as well. And there are some other things here as well about looking into the person's support network, being curious about their family, their friends, what those relationships are. Offer an understanding statement. For example, I understand that the problem with your neighbours is really affecting you. There's loads of really good top tips there that you can actually take away with you today and start putting into practice straight away. So some other tools that we have are trauma-informed practice work streams. So I'm not going to go through all of these because we don't have time, but they are on the slides. But trauma-informed work streams, and this you won't be surprised to know is focused on the PDU, which have some amazing, excellent resources. And we signpost people to the PDU quite a lot, and we do have it on our website as well. They have a whole range of information about trauma-informed approaches. There are national and local resources, and there are reports about how to put it into practice. There are reports about how to support people and rapid evidence assessments. There's a huge amount of information there, and I cannot recommend it enough. So there we have some resources that can help you in your practice, and hopefully things you can take away and start using today. So I'm going to move on to Howard, and this was the second case, and this was quite a different individual from Thomas, quite different situation. So he was 53 years old. He was found dead by a member of the public in a bus shelter, and that bus shelter, he was homeless. That actually where he had been living, I guess, was in that bus shelter. He had a heart condition. He took prescribed medication. Although his use of that medication was described as quite chaotic, he found it quite difficult to manage that medication and stay on top of it. He was frequently taken to A&E because of that. He had a very long history of alcohol use starting in his teens. His drinking increased heavily following the death of his mother. He neglected his business after that, and he was subsequently jailed for fraud. When he was released from prison, a cuckooing gang moved in, and he was soon made permanently homeless from that. One of the issues he faced was that in the area he was in, the homeless hostels did not allow alcohol, and that's quite common. There was a view from some of the agencies, in particular housing, that he clearly didn't want to be housed if he kept drinking, and they had ample opportunities to stop. He was a frequent victim of exploitation. His medication was stolen, and he experienced violence while he was street homeless. His cause of death was found to be cardiac arrest, as well as alcoholic liver disease, heart disease, and heart atheroma as well. So we have quite a different picture. But when we look at some of the key areas of learning, there are some that are very similar to Thomas, very similar to the first case that we looked at. So we had multi-agency meetings that were not well attended by key people. They were invited, but they did not attend. Lack of communication between services in two different areas. He was between two local authority areas and two different health providers, and there was no handing over of paperwork, and there was no communication there, and things got very confused. Lack of safeguarding referrals made, and self-neglect not recognised. Each encounter with services was sealed in isolation, so there was no opportunity to build up a picture of some of the challenges that he was facing. Perception that alcohol was a lifestyle choice. I have seen this in a huge amount of safeguarding adult reviews in the last 10 years. And I personally think that's never acceptable to see in somebody's notes and to have that approach. Lack of understanding about other services, pathways and thresholds. And this can tie into some of that lack of multi-agency working. There were sometimes assumptions made that, oh, that agency is dealing with this because that's what they do. And once I've made this referral, that's them now dealing with it. I don't need to do anything else. But those agencies, it wasn't their remit to do the rest of the work. So there was a bit of a misunderstanding about whose remit it was to do what other agencies can and should be doing, which led to assumptions that things were being done when they really weren't. Again, we have mental capacity coming up as an issue. Lack of feedback from adult social care. It would be good to hear in the chat if that's something that other people have experienced locally when a referral is made to safeguarding. Do you feel like you get feedback? Are you assured that the case is being looked at? Some of the agencies here felt that making further referrals was pointless as it didn't result in any response, and they didn't get any feedback to say that anything was being done. Howard's case was approached in crisis mode. That's also quite common as well. It takes things to get to, somebody mentioned thresholds earlier on. It can take things to almost get to crisis point before everyone kind of pitches in and says, what can we do here? And how can we all work together? Housing did not class Howard as priority need or vulnerable, but they didn't have the full range of information. And when we look at our first case of Thomas, he again was not categorised as priority need because adult social care and some vital information was missing from that assessment. So even though these are two very different people from two different ends of the country, different local authorities, different agencies working with them, we are starting to build up a picture and see some similarities of where things can go wrong, and we are seeing similar themes and similar learning coming through them. So when we look at some of the learning from Howard, we have a lack of understanding of other agencies' roles and responsibilities. We have people thinking it's a lifestyle choice about his alcohol use. Again, we have mental capacity coming up, but also recording as well, recording of mental capacity and information sharing between agencies. And again, we're just going to put those 3 questions up. And are these themes, again, I am going to do the thumbs up again or show of hands, whatever you feel more comfortable doing. Are these themes what you expected? Is there anything here that's a surprise to you? So these are things that you're already familiar with that seem to be coming through. And that's probably from your day-to-day practice as well as local reviews as well. So they are reinforcing what we already knew because they are quite similar to the ones in the first review as well. And again, that 3rd question, and the anonymous form is there if you want it. If not, you can always put things in the chat and it will be looked at after the webinar. Why are they so difficult to overcome? If we know what the issues are and we know what the problems are, why do these things keep coming up? And I would say that in the last 10 years, these themes have been coming up more or less from the start. So they keep coming in, and I have to say that when a new referral comes in, my heart sinks when I look at it, and I can sometimes see before we've even started that it's some of the same themes that have come up before and some of the same issues that we can't seem to overcome. So a few tools and resources relating to Howard and some of the themes that have come up from Howard, and I will just switch to my other screen. So a quick show of hands if you have heard of Alcohol Change UK. A couple, but maybe not so many. Okay, so I'll introduce you to Alcohol Change UK. They are a national charity. And they do some excellent work. I'll just go to the top of the page so you can see it, and the link is in the slides. So Alcohol Change UK are a charity that provide help and support for people, but also do an awful lot of work with practitioners and agencies as well. They are actually authoring a safeguarding adult review for us in the city at the minute with one of the themes of alcohol use, and they have a huge amount of resources here. If you are with an organisation or an agency that might have some budget for training, they do offer some excellent training. It does come at a cost. But if you're not in a position to be able to do that, they do have some great articles and professional resources there. They are trying to make a huge change in how people view alcohol use, and especially through safeguarding adult reviews. So a few years ago, they did a learning from tragedies review, and this was a collection of safeguarding adult reviews across the country where alcohol use had been a theme in the person's death. Now, this was used as a catalyst to do a lot of work with safeguarding adult boards and local authorities, but also to lobby government about changes in the Mental Capacity Act and how that is applied to dependent drinkers. Now, those changes are still being considered. We know there's still changes in legislation being looked at all the time. But if they are successful in that, and there is a change in the Mental Capacity Act and how people apply it, that affects everybody. That affects everybody in all organisations and could make a huge change to the people that they support. So it's a bit of an example of how strong the learning from safeguarding adult reviews can be, but also how some of these organisations are really driving change and leading the way. So I'm a huge supporter of Alcohol Change UK, and they have some great resources there if you're able to go and have a look at them. So the other ones there are some about using the Mental Capacity Act and one in relation to alcohol-related brain damage. And one of the other ones I want to look at is around recording decisions. As I say, I'm not a Mental Capacity Act expert. There is a lot of information about there, but some of the things that came through was around recording and how to record things well on a system. We have seen with safeguarding adult reviews, all kinds of recording. There's a whole spectrum there. Some of them are very good with a lot of detail. Some of them have too much detail. Some of them just say capacity assessment undertaken. So there's no information about how it was done, what questions were asked, what the outcome was. There's a whole range. And when you are sharing information with other agencies, it can make things very difficult to put the next steps in place if you haven't got the right information from notes that are handed over. So there is a resource here. I'll try and move that. It is aimed at social care, but I have had a read through and everything is kind of applicable to everybody. You don't have to be in social care to be able to use these. It goes on the importance of recording. It has 3 short videos and it illustrates the harm that can be done if recording isn't done well. We've seen in safeguarding adult reviews firsthand what happens when recording is done poorly. So there are 3 videos that you can look and they come from different perspectives, but also the key top tips here are something called an acronym called partnership as a checklist when you are recording information on your notes. And it's to emphasize that the record should be co-produced as much as possible between you and the person to whom it relates. So person-centered, you should have person-centered notes that puts the person at the center of what you're talking about. The information should be accurate. That should be a given, but it always should be accurate in the notes. Real, and I'm going to go into this one and explain a little bit more about what this needs. Sometimes there can be some vague wording, and we have seen this in SARs as well. When aspects of particularly when people find it something that's difficult, for example, inappropriate sexual behaviour, and it's finding that middle ground between having something that is respectful for the person, but informs as well. For an example is using she had issues with personal hygiene instead of she smells revolting. There's quite a big difference in the language that's used and how that's recorded. So a more explicit example would be, due to her advancing dementia, Rowena often forgets to have a bath, resulting in an increasingly unpleasant personal odour that I think is having a negative effect on her relationship with her neighbours. It might take longer to record, but it identifies precisely what the issue is. It's respectful to the individual, and that will not just help other agencies in their immediate response when that information is handed over, but also when you think about learning from safeguarding adult reviews and inquests and things like that. It's always about making sure the information is accurate and real. Timely, it should be done in a timely fashion. No jargon, plain English. Try to avoid acronyms, even though I know that they will be used quite a lot in your own agency or your own organisation. You will be working with that. Multi-agency working is something we really try and promote, and they may not be familiar to other people, and they may not have the time or to go back to you and ask what things mean. It may be discussed in meetings, and you may not be there to answer to say what those acronyms mean. So try and do things in plain English. Try and make sure it's evidence-based. Always try and make sure you read the previous record. One of the things that came through in the reviews that we were talking about, it was Howard, was that things were seen in isolation. There was no looking back at some of his previous encounters with that own agency, as well as looking at what happened with others. So try and read the previous record and see how things relate. It should be succinct. It can make things difficult for people if they have a huge record to try and read when they're in a crisis situation. But to try and make that succinct as well. Try and make it holistic, try and make it IT compliant, and try and be professional in your language as well. So those are the couple of resources that I wanted to cover, specifically in relation to Howard and some of the learning that came through from that SAR. I have just seen that someone hasn't put cuckooing isn't yet a criminal offence in the chat. Just as an aside, we are doing some work with there's a national cuckooing working group for the national network of SABs. We have very recently had a safeguarding adult review where cuckooing is a feature. It's called Chris. I will put that in the chat as well. It's published on our website that relates to cuckooing, and it's not yet a criminal offence. And from that working group, we have actually had a direct route to work with the Home Office on drafting some of their new guidance, and some of the learning from SARS is going into that. And you may be familiar with the SARAC, the Slavery Exploitation Risk Assessment Conference, that is based here in Nottingham City and was the first in the country. So that team is also in that working group and talking to the Home Office about how things can be strengthened around cuckooing too. So just as an aside, that's also the strength of safeguarding adult reviews. Sometimes you can see these things that never change in the same themes and can get a bit deflated, but sometimes they can be a massive force for good as well. So let's move on to the last case, and this is Robin, so another different individual from another area. Again, he was 27 years old. He had a diagnosis of autistic spectrum disorder, paranoid schizophrenia, and seizures as well. His history had that he didn't want to engage with professionals generally. He didn't really want to engage with his family either. He wanted to be left alone. Over the course of his life, he had quite a large number of psychiatric admissions and contacts. His history contained social isolation indicators signifying multiple disadvantage, and these included he had challenges with his mental health. He was exhibiting signs of self-neglect, alcohol use, eating disorder, and in general he had quite a lack of understanding about his physical health and his mental health diagnoses. He was reluctant to engage with professionals and agencies. Again, that's the language that came from the SAR. He lived a very secluded life, but this was often in very poor conditions that he lived in. He was very sadly found dead in his flat. This was following an unrelated police call, and his body was actually in an advanced state of decomposition, and a cause of death could not be concluded. His family have expressed upset and anger and confusion. They were under the impression that he was in supported living, and that he did have agencies and wraparound support around him, which wasn't the case. So when we move on to some of the areas of learning, sorry, there's an awful lot on this side. I maybe should have put it on two. Again, we see there's a crossover between non-engagement and self-neglect. And I think agencies in this SAR found it quite difficult to understand where that threshold is, that crossover is between when is it somebody is living a certain way because they have capacity to make those decisions and they're happy and comfortable that way, and when does that cross over into self-neglect? His discharge, again, was uncoordinated and not all the agencies were included. So the GP wasn't included, and therefore they missed out that he was entitled to Section 117 aftercare, which was a really significant piece of information. So that's all three of these reviews have had a discharge which was lacking the right information, all the agencies weren't involved, and there was potentially decisions made there that could have been or should have been challenged. So letters were sent out to him without considering his state of mind, whether he was able to understand the contents. And when it comes to people who don't engage, the onus was very much on him to get in touch with the services rather than the services being the ones to reach out to him and help him to engage. There were specific toolkits and resources about optimizing communication where individuals have autism or they are hard to reach, but agencies weren't using these. These weren't promoted. So they took his self-reporting at face value. Decisions were made in the absence of relevant knowledge. They didn't consider his complex mental health history and mental illness history and his special needs and non-compliance with taking medication. There was a missed opportunity to explore with his family. They would have known for signs of relapse, and this came up in one of the earlier SARs earlier on, is that sometimes friends and family and people who are known can have that vital bit of information, and that comes in about professional curiosity as well, about talking to them. His non-engagement was viewed as he didn't want to engage with services. It wasn't viewed in terms of his mental illness, his learning difficulties, or his suspected autism. There was limited professional curiosity again, unfamiliar with self-neglect guidance. Again, mental capacity was coming up. When he couldn't be contacted, professionals had put it down to he just doesn't want to answer, he just doesn't want to engage. It wasn't considered the worst case scenario that something may have happened because he wasn't able to manage his medication and wasn't able to manage his self-care. So relevant information about his history, about autism, and that he had an EHCP in place, this wasn't shared widely. This was not communicated between different agencies, which meant in turn that his assessments were missing vital information, and decisions were made on the wrong information, really. So we have, again, the same themes that are coming through with the first two. Non-engagement, I have put that in commas there. So professional curiosity, lack of family involvement, and also that there were tools, guidance, and resources there that weren't being utilised by professionals. Again, I'm going to ask for thumbs up. I'm going to ask because it's quite difficult to manage the chat and put hands up for discussion when we've got 48 people and we do only have an hour. So again, are these things that you were expecting? Are these things that are familiar to you, the themes that are coming through in this case? Again, we're seeing lots of thumbs up and we're seeing lots of hands up as well. So I know that they're not new to you. I know that they're coming up in your everyday practice and that they reinforce what you already knew, really. And again, please feel free to be open and honest in the chat about why they are so difficult to overcome and what the barriers are, because part of this session is about helping share the learning, but it's also about feeding back to the people that need to hear it what the barriers are, why we can't overcome these, what things need to be done differently, what things need to change, not at a frontline practice level but at a leadership level. And we'd have an opportunity to feed that back and raise those. So please do feel free to put down honest opinions there. So a couple of tools and resources just from the last one as well, and these are to support non-engagement. So I'll go to these on my other screen. So, and this is from the NSPCC, which I know relates to children, but everything here is very relevant. And I thought that this was an article that put the language in a really good frame. So we've got why language matters, and are people really hard to reach, or is it that services are hard to reach? And I'm pretty sure everybody on the call knows that it's the latter. It is very difficult sometimes to approach services. And in this article, it tells you not just the impact of having that approach, but also of using that language and using that language in notes and in training and things like that as well. It gives you some information about what some barriers are to engagement, stigma within the community or amongst friends for seeking help, lack of familiarity with an awareness of a service. People may not know some services exist. They may not know the support is out there as well. Historic lack of trust in services, that comes through quite a lot, and I think that can be part of trauma-informed practice as well. Some people have had really awful experiences with services in early life as well, so that is going to be a barrier for them. Issues around availability, long waiting lists, inconvenient opening hours. Things don't happen 9 to 5, Monday to Friday. They happen 24 hours a day, 7 days a week, and not all services are there. There are some tips about what you can do to reduce barriers, but when we look at something local, what we have is there is a framework that exists. And this is the Improving Agencies Engagement with Service Users framework. Some of you may be already familiar with this. Now, this was developed by the Community Safety Partnership and endorsed by the Safeguarding Adult Board. And it has some really good information there about how you can make a referral to the multidisciplinary team in framework, but also some tips about engagement, even if you're not making that referral, and how you can work with people. That is a really good resource. It's 24 pages long, so I'm not going to go through it. I would suggest that you sit with a cup of tea and go through it and just absorb all the information in there, because it's a really good piece of guidance. So we'll just move back to the slides, and the last little section that I just want to cover, because I know we've only got about 15 minutes left, is the second national SAR analysis. And I think this is just to reinforce that these themes are not unique to these reviews, and they're not unique to Nottingham either. This was a review of all the safeguarding adult reviews between 2019 and 2023. So there were 652 in total. And what came through from those, and some of the things that resonate with what we've looked at today, is that there was 60% of all safeguarding adult reviews between those years featured self-neglect. It is a huge area, and it is a huge issue. It was the highest of all the Care Act abuse and neglect categories. 82% of these reviews had poor risk assessment or poor risk management, and also poor use of safeguarding. So recognising when those referrals need to be made to adult safeguarding was a key feature. 23 of them, poor attention to living conditions. When we look at Robin, the last case, it does say there that he sometimes lived in very poor conditions, and that wasn't always picked up or noted. Poor attention to substance misuse, that was in a fifth of all SARs. Nearly half, 44%, absence of professional curiosity. Poor recognition of trauma and lack of trauma-informed practice was nearly a quarter of them. That's a huge amount of safeguarding adult reviews when we think that there's 652 of them that's coming through. Absence of attention to mental capacity, that's over half. And when it says absence of attention, that sometimes means not carrying out assessments and not recording things around mental capacity assessments as well. It wasn't all bad. There was some good practice there as well. And I think it's important that sometimes we highlight some of the good practice. Although that's not what SARs are necessarily made to do, it is always important to note that there is some excellent practice going on both locally and nationally. So some of the good practice that came up in the Safeguarding Adult Review national analysis was that actually 31% had a good approach to risk assessment and risk management, and this had a positive impact. Good use of person-centered approach in making safeguarding personal. We use the term making safeguarding personal a lot. I know to some people that can be quite a social care term, although it is a Care Act term, not a social care term. But it is person-centered approach and patient-centered care. It's all of those things. Good continuity and perseverance with the individual. That can be quite difficult when sometimes people you don't always have that opportunity to see the same practitioner every time and build up that rapport with somebody. But having that continuity and having perseverance with an individual when they find it difficult, when the service is difficult to engage with, came through in 22% of them. Trauma-informed practice did come through as good practice, but it is only 5%. So I think that's an area where there is a lot of work that we can especially do as a board with promoting that and ensuring agencies are putting that into practice, and also building any resources to complement what there is already in the PDU and locally as well. But some of the things I wanted to pull out was, and these are quotes, is that some of the personal qualities. One was compassion, kindness, care, empathy, and sensitivity were all noted, along with commitment, dedication, professionalism, skill, and diligence. Even though people are finding it quite difficult to put some things into practice, there are some really good personal qualities there. And I'm sure that there are many people in Nottingham City that have these qualities as well. The ability to see beyond the presenting problem and to find and respect the person beneath. And that really struck a chord with me when I read that. Relationship-based practice. The efforts that practitioners made to build relationships that were sometimes the key to agencies being able to maintain contact. And that's the important thing. It's that professional curiosity and learning about the person and that trauma-informed practice, but also working on that, helping them to engage with services as well. So those are just some of the personal qualities that came out. So some final thoughts from me before we go to any questions. I feel a bit like Jerry Springer for those who are old enough to remember. And there are a lot of things that came through in these reviews, but some final thoughts from me were, there are a lot of assumptions about what other agencies can, can't, should, and shouldn't do. And really that it's about communication is the key. We are all supposed to be on the same team and we are all supposed to be working together. And I know that there are barriers between agencies that can make that difficult. But sometimes it is about just picking up the phone and talking to people. It is about trying to learn what other agencies do. So you can say, okay, so yes, they'll deal with that bit and I'll deal with this bit. And it is about building relationships, not just with the individuals, but with other agencies as well. And people come into this sector not because they want to care for people, but because they care about people. I don't believe that anyone gets up in the morning and goes to work and deliberately wants someone to come to harm or end up in a SAR. People want to make a difference. People want to support people and make their lives better and improve their outcomes. And I think sometimes it can be the policies and the procedures and the thresholds that get in the way of that. And also, I've talked sometime about leadership as well. Leadership is within everybody, I believe. And I don't think it's just for those people who sit at the top, people in director positions. I think everybody has leadership skills and is able to bring them to their day-to-day role. Doesn't matter where you sit in any organisation, you can exhibit those leadership skills that can make a big difference. Um, and just this last bit here is we have recently launched a new website. Please bear with us, it is new and we are having some teething problems. But when the slides go out, there is the link to the bottom to our website. We do have, it is mainly aimed at professionals. There are some parts for members of the public, but it is the target audience really is professionals. And we would try to bring together some local resources, national resources. The Nottingham Safeguarding Adult Board doesn't actually commission training itself. We don't have a budget, but we will try and signpost to some of that national training, some of those national and regional workshops and webinars as well, where we think that they'll be useful for people. We try and complement the PDU as well, and we also signpost people there. So I'm going to stop now and ask if there's any questions, and I'll stop sharing the slides so I can actually see the screen, and hopefully there's a few in the Q&A, and if not, then you can feel free to ask them now. Thank you.
Oh, thank you, Emma. That was really interesting. There's lots of comments in the chat box that you'll be able to go back to
Brilliant.
after the session and see what people's thoughts and things have been around the presentation. So we've got a couple of questions in there, but if anyone has got any other questions they want to just pop in the Q&A box while we're going through these, that would be great. Thank you. So the first question asked is to fulfill the criteria for a SAR, does a person's care and support needs need to have already been established?
No, they don't. So when we get a SAR referral in, we would go out to agencies and ask for information, and not everybody with care and support needs is receiving a package of care from adult social care. So even though we would ask adult social care for information, if they are not open to them, if there is evidence from other agency records that they would have care and support needs, they would still be considered for a SAR. So yeah, hopefully that answers that.
Thank you, Emma. There's another question here that asks, were there any differences reflected in the findings regarding the experiences of women?
It's not something that we looked for, but it is something that I could go back and look at. What I would say is that the ones we had regarding institutional discharge, the overwhelming majority were men. There were a lot more men in that category than there were women. There were some that weren't published as well that we were able to get access to because we weren't sharing the information, the names and things. So I will go back and have a look at that actually, because it's not a question that we looked at when we were reviewing them. So.
Thank you, Emma. So there's just another comment here that says it would be useful to have a case study from a woman in a future session. So
yeah.
So there's another question here that says, with substance use being a common feature, is there any work being done to address challenges with adult social care declining to do care and support needs or capacity assessments, and inverted commas blaming the substance use?
I'm not aware that there is. I don't actually work for adult social care. I work for the board. And I wouldn't be involved in any of the operational work around adult social care, but I can certainly take that back and ask. We do have a route to take this on the board, and obviously adult social care is one of the 3 statutory partners. So we do have a mechanism there to take any questions back to them, and also challenges as well. So I will take that back as a challenge, happy to take that. And if you wanted to put your name in the chat, I can feed back to you as well.
Oh, lovely. Thank you, Emma. That's the end of the questions that we've got. I don't know if anyone's got anything that they want to quickly type in the Q&A box before we just close the session. Like Emma said, the link for the anonymised feedback form in relation to what's been discussed in the presentation is in the chat box, but it will also be in the feedback email as well. We'll add it to that so people can complete that, and we've asked for 2 weeks for people to do that, and then it'll all get fed back anonymised to Emma. Then I think we've just got another question that's come in, Emma. So are there findings relating to ethnicity?
So what we've found, what this came through in the national SAR analysis, is that sometimes, well, a lot of the time, protected characteristics aren't being listed in the SARs. So there weren't necessarily anything that stood out in terms of ethnicity. The ones that I looked at today were all white British. I can have a look through and get some stats about how many were from different ethnicities. But it is a bit of an issue in SARs that the ethnicity is not always recorded. So that's something that has gone out as a learning point to all SABs across the country, that when they're commissioning them, they should be looking at those protected characteristics, and then it can make the analysis a little bit easier. So.
Thank you. So I think that's it for the question. So we'll end the session there, if that's okay. And thank you, Emma, so much for presenting today. It's been really interesting and informative. And thank you for everyone attending, and all your comments in the chat box and your questions.